So when it comes to acromegaly, you should be very clear. Whenever there is a growth hormone excess, you can call it acromegaly, and it can be due to a primary issue with the pituitary per se, or this growth hormone can be coming from some other area. It could be coming from a neuroendocrine tumor, or rather than growth hormone, it would be the growth hormone releasing hormone, which is in excess and which is going to stimulate your growth hormone secretion. So accordingly, you may have a primary growth hormone excess syndrome, or an extra pituitary growth hormone excess syndrome, or a growth hormone releasing hormone excess syndrome. So we'll see the basic differences. So when we talk about primary growth hormone excess, it directly means that there is a problem with your pituitary. There is a problem with the pituitary cells which are producing the growth hormone. So it could be a pituitary adenoma. And based on the different histological characteristics, there are a lot of different types of growth hormone adenoma. It's beyond the context of any PG teaching. It's more like a super specialty part. But at least get to know all the different types. Densely granulated growth hormone cells, sparsely granulated cells, mixed growth hormone and prolactinoma. I told you earlier, initially when the differentiation happens, we have a cell called as mammosomatotrope. Only then further transcription factor will act on these cells and further mammotropes and somatotropes will de-differentiate. So when some tumor occurs in the primitive cell, you may have both growth hormone and prolactin coming together. Okay, so mammosomatotrope, acidophil stem cells, plurihormonal tumors are all concerned with multiple other hormones along with growth hormone secretion. And very rarely you may have a silent somatotrope also. That means not the entire growth hormone, not the biologically active growth hormone, but the growth hormone fragments may be secreted by your pituitary adenoma. So very rarely pituitary carcinoma may also produce growth hormone, but it's very rare. By the time it turns out into a carcinoma, the secretion will start coming down. It will start to de-differentiate itself. It won't be able to produce the hormones, but it would be de-differentiated, and you may see those issues. Can we have ectopic growth hormone excess? Growth hormone produced by an ectopic source. Can it happen? Yes, very, very, very rarely it can happen. This is because growth hormone has more than 150 amino acids. So it is a bigger molecule. So obviously it would be very difficult for a tumor to secrete all these 150 amino acids in toto. It would rather go and secrete a 44 amino acid moiety, like your growth hormone releasing hormone, rather than a growth hormone per se. So when you look into the neuroendocrine tumors, they most commonly secrete GHRH. See, bronchial carcinoid, pancreatic neuroendocrine tumor, small cell lung cancer, adrenal adenoma, medullary thyroid, and pheochromocytoma, all are neuroendocrine tumors. So they produce a smaller variety. They can produce growth hormone releasing hormone, which is in turn smaller compared to a growth hormone. So this is more common in a neuroendocrine background rather than a proper growth hormone excess. And definitely you have to know about these familial syndromes. What is MEN syndrome? What is McCune-Albright? You would have heard about it, right? So it's a problem directly with your receptor per se. It gets constitutively activated. So rather than a hormone coming and stimulating other hormone, the receptor per se gets activated, and you will have a growth hormone excess like syndrome, but the growth hormone may not be in plenty. And familial acromegaly and Carney's complex or certain neuroendocrine, multiple endocrine neoplasia syndrome. You will learn about what is MEN syndrome, what is Meon syndrome, multiple endocrine and organ neoplasia syndrome in the upcoming chapters. But at least get to know about what are the types in which acromegaly can happen. So it can happen in multiple endocrine neoplasia type 1, McCune-Albright syndrome, familial acromegaly, and Carney's complex. And the second option is extra-pituitary GHRH. So this can again happen, as I told you. It could be an ectopic source. It can come from the pancreatic islet cell tumor or lymphoma or hydrogenic variety also. So you may have extra-pituitary growth hormone excess also. So whenever we think about acromegaly, the most common, more than 98% of the total acromegaly would be due to primary GH excess only. The rarer 2% may be due to the extra pituitary GH excess or GHRH excess. Among these two, GHRH excess is more common. So at least that chronology you will have to know. So, what is acromegaly? I told you earlier the basic differences between gigantism and acromegaly. Gigantism is growth hormone excess happening in non-fused bone. So there would be an extraordinary linear growth rather than the terminal growth, which happens in acromegaly. Whereas in acromegaly, the bones have already fused, so there is no possibility of that patient growing further, but the patient may expand. There may be abandoned soft tissue growth that can happen in these patients. So, what can happen in acromegaly? What could be the clinical manifestations? So, there could be a pituitary enlargement. Obviously, due to the local compressive effect, which I have seen in the previous chapter, there could be a visual field defect. Okay, so initially there could be a bitemporal hemianopia followed by complete blindness also. Cranial nerve palsy. If the tumor is encroaching your cavernous sinus, ending up hitting your cranial nerves. Obviously, cranial nerve palsy will come and headache due to the raised ICT. And not only that, in acromegaly, there could be a dural thickening. So the dura may go in for further thickening. There could be a hypertension which can cause headache. And obviously, due to the acromegaly per se, the tumor per se will be producing a lot of nociceptive peptides, which will produce nice headache. Even if the tumor is small, the patient will complain of headache. And we can attribute it to anything rather than the nociceptive peptides which are getting released from your tumor. So these were the local tumoral effects. Moving on to the somatic effect, obviously acral thickening would be there. Thickening of the soft tissues in the hands, feet, and any flat bones like your jaw, they go up for a gigantism. There could be prognatism, and because of the jaw enlargement, teeth malocclusion can happen, and because of the soft tissue enlargement, connective tissue enlargement, you could have spade-like hands and carpal tunnel syndrome, and terminal neuropathy sort of features can have, which we call as acroparesthesias. Okay, and growth hormone will also have some level of catabolic effects over the muscles. So with time, proximal myopathy can happen. Okay, and hypertrophy of the frontal bones can happen. What happens to the skin? It has a direct provocative effect on the sebaceous and sweat glands, growth hormone. So there will be hyperhidrosis, oily skin, and because of the IGF-1 excess, there could be excessive skin tax happening in the patient. And the same thing may happen and may corroborate with your colon also. There could be polyp formation in the colon. So moving on to the cardiovascular effects. Obviously, the common effect is hypertension. So it's going to cause hypertension, and apart from that, the cardiac muscle mass may increase asymmetrically. So there could be asymmetric septate hypertrophy due to the hypertension. There could be left ventricular hypertrophy, and long-standing cardiomyopathy and congestive heart failure can happen. Pulmonary, in that part, you may have obstructive sleep apnea. Okay, and due to the tumorogenic effect, there could be central sleep apnea can also occur coexistently, and obviously narcolepsy may sometimes happen in these patients. And we will have acromegaly. So liver, spleen, kidney, even kidney and prostate will start to enlarge, and tongue, thyroid, and even salivary glands starts to enlarge. You may see everything. And breast enlargement is also very common because GH also starts stimulating your breast epithelial cells. So not only that, IGF-1 will also have increased IGF-1 level in the breast tissue that may also have increased breast enlargement. So males may present with gynecomastia. Sometimes, if prolactin is co-secreted with it, they may even have galactoria. And menstrual disturbances, obviously, due to the direct GH effects. Not only that, because of the tumor per se, there could be suppression of the gonadal axis, and because of the menstrual disturbances can happen. Galactoria, decreased libido, impotence may happen. And if that particular patient belongs to the men type 1 category, apart from pituitary adenoma, there could be a parathyroid hyperplasia along with a pancreatic islet cell tumor. So they may present with carcinoid syndrome and increased calcium levels, along with increased PTH, which is attributed to the parathyroidism. And obviously, growth hormone is a hormone which is going to cause more of insulin resistance. It's a counter-regulatory hormone, right? So you may definitely have impaired glucose tolerance, triglyceridemia, diabetes, hypertension. The entire spectrum of the metabolic disorder can be seen. Hyperuricemia may be seen. So deranged lipids, blood pressure, cholesterol, and carbohydrates may occur together. It has a direct stimulatory effect over the adrenal cortex and increases the aldosterone level, and thereby adrenaline level will go low. And not only that, it causes erosion of the bones. So hypercalcemia will occur. Okay, and this excessive calcium that is being eroded from the bones is being pushed to the urinary tract, and this results in hypercalciuria. It also has a direct stimulatory effect on the thyroid gland, and they may present with multiple nodules, goiter, etc. And the risk of carcinoma is also higher in acromegaly patients compared to any other non-acromegalic nodular patients. So these are all the clinical characteristics that we generally tend to see. But typical acromegaly patient, we can easily make out. In the previous chapters and clinical vignette, I would have discussed about it. But very rarely people with young hypertension, which is very difficult to control. Uncontrolled diabetes, despite optimally treating them with other insulin and whatever therapy. If it is still uncontrolled, you will have to think more in terms of secondary diabetes. So think more in terms of Cushing's or acromegaly. Similarly, obstructive sleep apnea. In otherwise okay patient, if you see obstructive sleep apnea happening, definitely you should think more in terms of acromegaly. So these are all the common features of acromegaly.